So I will start with my presentation. Thank you, Dr. Medical, for inviting me to this talk. I am Dr. Aleksandar from Chile. I work in Hospital del Trabajador y Hospital de Carabineros de Chile. My talk is about the importance of medial wall in intertrochanteric fractures. So I don't have conflict of interest with this presentation. You know that outcomes in intertrochanteric fractures are composed with clinics and mechanical factors. So in clinics, we know that mortality rate is over 20 to 30% in 1 year. Most medical complications are in our patients. Heart disease is an important part of these complications, and they also have problems with quality of life. 80% end with restrictions in daily life activities, and 50% do not achieve independent gait at 1 year. So, but we also have the mechanical problem. In Chile, for example, we are projecting that our increase in hip fractures will be around 21% and 30% to the next years. So also the mechanical failures are important in these patients. We know that these have occur in different type of patients. These two papers shows you that with different implants, you can have around 20 to 10% of global failure with migration, cut through, cut out, implant failures, and peri-implant fractures. So this is an issue that we have to attend. So which fracture might fail? First of all, we have to take into account which fractures are unstable fractures. So some authors in some papers said to us that bone quality, the fragment geometry, the choice of the implant, the quality of the reductions, and the placement of the implant in the femoral head are the most important factors to have a good outcome in stability. You know that in 2018, the AO updated the classification of this type of fractures. They focus on the instability when you have a combination of posteromedial fragments and lateral wall incompetence. They define this with less than 20.5 millimeters. Also, when you have a reverse oblique fracture. But is this enough? For example, this case is a 2.3 fracture. We did a TFNA. This is the implant that we use, and you can see we have a good reduction, good position of the helical blade, but this case, failed, and this fail probably we will know why it occurred. Also, this case you see is a complex fracture, a complex fracture because the lateral wall is compromised, and a lot of comminution. We did this reduction. You see maybe the helical blade is a little higher in this position. So we also have a failure. So back to the anatomy of the fracture, we analyzed in this fracture we have different fragments. First of all, the head and neck fragment. also the femoral shaft fragment, greater trochanter, lesser trochanter, and the intertrochanteric crest. So in this study, you can see that in these complex fractures, only in this part, you have a good contact within the principal fragment, the head and neck, and the femoral shaft. This study of Lee showed us that with using 3D CT scans, you can see where the fracture lines goes. Most of them in the anterior part are just one fracture line. In the medial portion, you have this convergation of the lines from anterior and posterior, and compromising the lesser trochanter. Also, with the in the posterior face of the femoral proximal part, you can see you have a lot of comminution because a lot of lines, principally the intertrochanteric crest line, but also the greater trochanter and lesser trochanter can have a comminution. So, and also in the lateral view, you can see most of the fracture have a coronal line of fracture. So Dr. Chang explained us that this problem, and he said that always we have an anterior simple fracture line, also a comminution in the posterior portion, around 70%, and we also have this coronal plane lateral wall fracture line. So what do we have to do to take in account in the lateral wall? Well, the height of the thickness, and you know that thickness was defined by the Dr. Su, that we have a distance in millimeters from the reference point line, 3 centimeters below the innumerate tubercle of the greater trochanter, angle 135 upward to the line fracture line on the AP, and this was to be more than 20.5 milliliter, or we have an incompetent lateral wall. So, but also we have to take in account that the width of the lateral wall. You can see that this will depend of the coronal plane fracture, and Dr. Cho demonstrate that we have like 3 types of this type of fracture. So more greater trochanter, lesser, greater and lesser trochanter, and include the posterior medial shaft. So like I said, these are the 3 different type of fracture compromising the posterior part, and this is done because of this coronal fracture line, and we can see that if you don't know this, you maybe don't see it in the X-ray. In this study, they show us that 85% of fractures have you can see only in 3D CT scan. So you have to go and look for them. Also, you can see that almost 50, 60, and 40% of them are complex or are comminuted. So this is also an instability. So the posterior medial fragment is, you know, it's a constant fragment. Is maybe will be simple or will be complex, and it's very variable and it's very unstable. So in 80% of the the times. It includes the calcar, and if you take in account the whole shaft, it's take 39% of all the circumference. So you can see now that posterior medial fragment is not the one you can rely on when you're doing your reduction. So the only thing you can rely on is the anterior medial fragment. So Dr. Chang said us that when you do reduction, you're doing the reduction of these fractures, you have to take in account alignment, displacement, and the reduction quality, as Dr. Baumgarten says in the 80s. So, but in this case, he said that you don't have to focus on the only numbers. So you have to put your reduction in the anterior, in the relation of the anterior part of the femoral, of the head and neck and shaft of the femur. So and this will give you primary stability, and the buttress support will give you secondary stability, and this will do your implant. So extramedullary implants goes too lateral, and they can fail because of that. So intramedullary and more medial buttress could give you good support and secondary stability. Why is that? Because you need to also have a cortex to cortex a position. You can see here head and neck and shaft, and this is the point where you can have a good support. So when you have this contact, you can have a good support, and you can prevent for varus and posterior shifting of your reduction. So Dr. Chang said to us that and recommend you to do positive in this fracture when you're seeing the AP X-ray. You can do a positive reduction. That's mean that you have one cortical step off in the medial part of the head and neck and shaft relation, or you can do also a neutral cortex to cortex contact. But when you have this negative cortex to cortex, when you have more than one cortical part, you may have failure. Also, with the axial X-ray, you have to meet a coaxial view of the nail and the screw or helical blade, and you have to have also a positive anterior head neck shaft relation, neutral or negative. And when you have a negative, you can have failures because you don't have a good buttress support. This is an example. You have here a positive AP relation. Here you have a neutral, and here you have a negative. So, like he says, when you have positive cortical support, in the fluoroscopy, head and neck fragment located slightly superior to the femoral shaft, and head and neck shaft angle valgus alignment. In the lateral view, anterior cortex of the head neck fragment located anteriorly to chaff cortex by more than half of the cortex thickness. And then when you have a neutral cortical support, head neck fragment located smoothly to the femoral shaft and neck shaft angle anatomic or valgus alignment. The anterior cortices made a smooth contact or step off was less than half of cortex thickness. And when you have a negative cortical support, head and neck fragment is spaced laterally to the medial edge of the femoral shaft, and neck shaft angle goes varus. The anterior cortex of the head neck fragment located posterior by more than half of the cortical thickness. And this patient with positive cortical support, a good battery support, they do more good in the functional outcomes, also because they have a good secondary stability. One of the tips they give us to do this is using this instrument to achieve the positive alignment. So like you see here, you can do this, and with this maneuver, you can get a positive contact of the anterior cortex. When to use long lanes, this is also important because maybe, like I said in the beginning, you have a little contact support, a little battery support between the head and neck and the shaft because of the convoluted 8.3 type of fracture with convoluted greater trochanter and lesser trochanter. So you don't have a good battery support. So in this case, we recommend to use long nails because this could fail in rotation and get our fracture in varus and in troubles. Also, it's important to make a good entry points. There are some tricks like using this type of guide to our wire to get more medial, and then take out this neck, this distal part of the neck that is very thick and gets our nail in varus position. This is another trick you can use. So in this case, we have this 8.2.3 fracture, and within this we have a negative, and we also have failure. But in this case, we have a neutral and positive in the axial. So we have a good outcome. Thank you very much. I hope I will get some message from our country.